Great to have Professor David Durrheim with us again. The second time we've been able to talk to David. First time, of course, at the initial stages of the COVID pandemic, and we were really just trying to find out what's happening. What is this all about? But this time we want to chat a little more about vaccines and vaccination. It's a topic that we're hearing a lot in the media at the moment. So first of all, welcome, David.
Oh, it's lovely to be with you, Wayne.
And just a reminder, David is, Professor David Durrheim is a medical doctor and also the Director of Public Health for Hunter New England Health, consulting professor for the University of Newcastle in public health medicine, and also a well-respected consultant with WHO, the WHO, and at an international level and at national level. And part of the expertise David brings to this conversation is working with viral outbreaks on the African continent, in the Pacific, and being right at the forefront of what's happening with the COVID outbreak in our own nation. So just so much appreciate your time today, David.
That's my great pleasure.
So maybe first of all, just give us a little bit of an update as to what's happening in Australia, where we're at the moment. Things seem to be so much better in regard to particularly our state of New South Wales, almost COVID-free, and our nation. So where are we at this point in time?
Well, from a global level, Wayne, COVID-19 continues to wreak havoc around the world. We've had now over 110 million confirmed cases worldwide and 2.5 million deaths. In Australia, we've had fewer than 29,000 cases, 909 deaths, which are tragic, but quite a small number of deaths compared to what's happening on the global level. And this really speaks to the huge effort that the community's made, that public health teams have made, and obviously due to divine providence as well, to have actually eliminated transmission in most of Australia, which is 28 days without any local transmission, is fantastic. And although our testing numbers are down in New South Wales, the sewage surveillance, which covers most of the population, indicates that there's no one at the moment shedding the virus in the community, which is wonderful. But as Melbourne Airport has shown, and quarantine hotel breaches in a number of states have shown, the virus can escape very quickly. And so we have to really be vigilant that we don't lose this hard-won elimination status.
And I guess talking about the virus, COVID, we're seeing reports of new strains of COVID from South Africa, United Kingdom. Is this just the natural process of a virus like this morphing over a period of time, or is it something we really need to be concerned about?
Well, look, all viruses mutate, and RNA viruses like the SARS-CoV-2 or the COVID-19 virus, they definitely mutate. Fortunately, this virus, unlike many other RNA viruses, has been relatively stable. Other RNA viruses like HIV are really mutate very quickly, and so impossible really to successfully produce a vaccine against them. They're changing, the target is changing all the time. But because of the relative stability of the COVID-19 virus, it's allowed us to really target its spike protein with vaccines. Now, these mutations are of concern. It's quite clear that the UK strain, or what we call the Kent strain, has actually, and it's become very dominant in the UK and now spread to many countries around the world, actually is more transmissible. So we think somewhere in the order of about 50% more transmissible, more infectious than the original Wuhan strain. And the South African strain appears to have escaped some of the natural immunity in a few individuals in South Africa who have been previously confirmed with infection, and they've been reinfected. So we cannot laugh off these mutations. We have to take them very seriously. Now, fortunately, we've developed a global laboratory network that fingerprints a large number of these virus strains, of the COVID virus strains. And this is very important. It allows us to monitor the mutations and then adapt our tools so that we can adequately fight against them.
Very good. So I guess what you're saying too in all of this, we can't, knowing what's happened at Melbourne in Perth, in different cities. We can't afford to be complacent. I guess people are wondering why governments are being so hard, our state and federal government, when we have an outbreak, and knowing that our nation is doing pretty well, can we afford to be complacent?
Look, I fully understand why people are getting a bit tired of restrictions. And so I'm actually not surprised at the complacency and the fatigue. But unfortunately, we cannot afford to relax. This virus, if it once gets a foothold in the community, can spread really rapidly. I'm on calls every week with colleagues around the world. They're incredibly envious of the situation in Australia. I think we've forgotten, we've lost that urgency that others around the world are still experiencing. The tragedy the virus is still wreaking internationally is really unprecedented. So we need this rollout of effective vaccines. It's the only way we're going to be able to resume an adapted normal way of life again. And until we have a large proportion of the population that are actually protected by vaccination, we're going to have to be careful. So the hugging and the kissing and handshaking of folks outside of our own household, no, thank you. And trying to keep 1.5 meters a distance from others, being very careful to use hand gel when we've touched surfaces that others touch. And clearly, if we do get a sore throat or a sniffle or lose our taste or smell, very important to get a COVID test.
Thank you for that. I guess a very challenging question is from our last interview and then just speaking to people, some would insinuate, David, that someone in your position or others in your position who are commentating on what's happening would perhaps not tell us the whole truth, or would, I guess the insinuation is, would lie just to protect the government, to keep Big Brother happy, I guess. And I know you, and I know not just as a medical professional, but as a wonderful, godly man, that certainly wouldn't enter the equation for you. But people are insinuating that there's a cover-up.
Well, look, first of all, let's go to the medical side of things. I take my Hippocratic oath very seriously. And that was something that's probably a bit of a legacy. I'm not even sure that they still swear the Hippocratic oath when they now qualify for med school. But the core principle is to do, first of all, do no harm. And I take that extremely seriously. That's been a guiding principle throughout my medical career. But those who followed my career on 3 continents know that I've never stepped away from speaking out where either government health departments or even international agencies have not followed the evidence or ethical principles. So principally as a Christian, I'm committed to truth. And as a scientist, I'm committed thoroughly to evidence.
Yeah, thank you for that. And again, knowing you, I'm very much aware that that is your heart all the time. And so again, thank you. There would seem to be a lot of medical professionals, or a few medical professionals, who are commentating in this space with different opinions. Some of them, as I've done research, are just medical doctors. Some of them are specialists in other areas. At what level can somebody in the medical field feel qualified to be commentating on what's happening with a pandemic outbreak?
Well, Wayne, if I was pregnant, and thank heavens I'll never experience that state, I would definitely be following the advice of my obstetrician and not of the orthopedic surgeon. So there clearly are medical super specialities where there are people who really are in-depth, profoundly across all of the science in a particular field. So when it comes to COVID, I'd be guided by the experts in the field, and that would be public health medicine experts, virologists, immunologists. Now in Australia, we're lucky. When it comes to vaccine effectiveness, we've got an independent group of experts called the TAGI, the Australian Technical Advisory Group on Immunisation. And that's made up of the appropriate specialities across various universities and research institutes that advise the Australian government. When it comes to vaccine safety, we've got a regulator, the TGA, the Therapeutic Goods Administration, and they are absolutely rigorous about safety assessments. And these are the two groups, the ATAGI and the TGA, that I would trust, who have the expertise to make evidence-based judgment and recommendations on vaccines.
So a good lead into talking about vaccines and immunisation. There's, again, armchair critics out there and armchair experts popping up with the social media forums having a chat about it. So we'll tackle a few of the questions. In Australia, we have two vaccines that are currently approved, the AstraZeneca vaccine and the Pfizer vaccine. What's the difference between the two of these vaccines?
Well, around the world, it's quite amazing the array of vaccines that are in various phases of development. We've got over 250 vaccines that are in different stages of research or clinical trials. But the vast majority, almost all of them, target the spike protein on the surface of the virus. And you might ask why? Well, that spike is absolutely essential to allow the virus to bind to a little receptor called an ACE2 receptor, which is very commonly found, particularly in our respiratory tract, but also in other organs around the body. And if it binds, the virus actually can enter the cell. So the spike protein is critically important to the virus. Once the virus enters the cell, it multiplies and it then invades many other cells. And if we allow it to continue with its infection, some people recover, but many actually go on and develop a more overwhelming infection. And that overwhelming infection can then kick in with a very destructive response, a non-targeted response from our immune system. We sometimes call it an immune cascade. Now, what the viruses do is prime our wonderful God-given immune system. They give it an early exposure to this particular spike protein, so that if we do encounter the whole virus, we're well prepared and our immune system can target it before it actually causes invasion and before it causes damage. And there are two ways that the immune system responds. The one is by developing antibodies. So we prime the immune system to develop antibodies against the virus, so that the minute the virus invades, the antibodies are ready, they recognize it and they neutralize it and kill it. And they're T cells, and the T cells can target any cell that the virus actually gets into and eradicate it early. So the luxury of actually waiting for natural immunity takes too long. It takes in the order of 10 days to 14 days, and that can be a death sentence. Much better to prime our God-given immune system so that we're ready and waiting for the virus, so that if it comes, we can eradicate it or annihilate it immediately. Now, the two vaccines that, as you mentioned, that have been approved, use slightly different mechanisms of priming our immune system. The Pfizer vaccine takes a tiny little snip of the RNA that only codes for the spike protein, nothing else in the virus. It only codes for that, covers it in a little bit of lipid, which allows it to get into the cell, and it doesn't get into the nucleus, and that's important. None of these vaccines that I'm going to speak about get into the nucleus of the cell. It actually gets into the cytoplasm of the cell, and that actually prompts the cell, our own cells, to produce a little spike protein, only that part of the virus, on the surface of the cells, and that primes our immune system. Now, the AstraZeneca vaccine uses a slightly different mechanism. It uses a Trojan horse approach. It uses a harmless chimpanzee cold virus that is unable to multiply in humans to deliver that little bit of genetic code that actually codes for the spike protein. And once again, once the spike protein appears on our cells, our immune system kicks into gear and it prepares us against a natural infection. Now, there are many differences between the vaccines. I've spoken a little bit about how they're delivered. They also need very different temperature requirements. The AstraZeneca Oxford vaccine only needs an ordinary vaccine fridge at 2 to 8 degrees. Pfizer, as we know, needs an ultra freezer, minus 70 degrees. And that brings with it real challenges in terms of getting it into remote areas or into tropical areas. So that's an important consideration. It really can only be delivered in hubs or places that have minus 70 freezers. We could talk about, is one vaccine better than another? And we really don't know. we haven't put the two vaccines against each other in a head-to-head test. And the trials that have been done have used slightly different comparators for the vaccine. So the Pfizer vaccine was compared to a placebo, which was just salt water. And the AstraZeneca vaccine was compared to a meningococcal vaccine in the two of its largest studies. So they haven't been compared against each other. What we do know is that both of them prime a really strong immune response. Both of them, that immune response seems to be very robust and lasts for a considerable period of time. Obviously, we're still counting because we're still in the early phases of understanding how long the vaccine protection lasts. We do know that the Pfizer vaccine inclined to be more reactogenic. So especially amongst young people, about 50% of young people will feel a bit fluey on day 2 or day 3, and then that quickly resolves. After the first dose, about 60% of young folk will feel a bit fluey on after the second dose, and that's much less common in the AstraZeneca vaccine.
Let's talk about efficacy and safety. There have been reports that, particularly with the AstraZeneca vaccine, that efficacy is as low as 60%. It would seem more with the Pfizer vaccine from reports that I've read, but also reading that flu vaccines that people have every year, their efficacy is below 70% anyway. So what is the effectiveness of these vaccines?
So in the clinical trials, and we're starting to get real population level measures, which is very exciting. But from the clinical trial data, you're right, the Pfizer vaccine, and shows that you've been reading broadly, Wayne, about 95% effectiveness in the phase 3 studies. And that's against symptomatic disease and included older people. The AstraZeneca vaccine, the Oxford AstraZeneca vaccine, recorded variable protection ranging from about 60% to over 80%, depending on the period of time between doses. So if you waited 12 weeks between doses, and a lot of immunologists would say that makes a whole lot of very good sense, you'd actually get more than 80% effectiveness readings in the clinical trials. Now, there was less data available in the older folks in the AstraZeneca, and that data is now becoming available and will be very robust over the next month or so from the US and from the UK. And obviously the TGA will update its recommendations on the basis of new data. But both vaccines, we have limited data currently during pregnancy and for immunosuppressed individuals. And trials are now underway in those groups as well as in younger teenagers. And obviously the priority at the beginning was older people, adults, because of the severity of disease in those groups. So both vaccines appear to be very efficacious. They both prime a very strong immune response. And clearly what we're seeing is, even if we do get escape variants, we may well have to tailor booster doses of the vaccines. And already we're aware that AstraZeneca, for example, is actually embarking on ways of particularly coding for the South African variant, so that we get an effective response, a maximal effective response against that variant as well.
So let's talk about safety, which I know a lot of people are concerned about, particularly knowing that these vaccines have come up fairly quickly. A lot of finance being sown into them. People are concerned that with the speed that they've come onto the market. How can we be sure that these vaccines are safe and haven't just been rushed out?
It's a great question. And look, we have to understand the reason why regulators in Europe, UK, the US, Canada went for emergency approval. I mean, thousands of people are dying every day in their countries. Yeah. And so it was critical that if they could see effectiveness and see safety, that they would actually approve the vaccines. But we've been fortunate in Australia. We've managed to control COVID, and as I say, eliminate it currently in most of Australia. And so we've been able, the TGA's had the luxury of going through a routine, thorough regulatory process where they've applied the same tools they would for any vaccine to these vaccines. And that gives me great confidence. There was a lot of pressure. So people were saying, well, why aren't they doing it faster? And the reason was that they wanted to be able to guarantee that they'd applied the same rigor that they would normally apply for any vaccine for regulatory approval. And I'm comforted by that. The other thing that's really interesting is that around the world, yesterday we went past 2 million doses of COVID vaccines that had been administered, and no specific safety signals that have currently been generated despite incredibly intensive surveillance, like nothing else I've ever seen in my own career. So the world regulators are taking this really seriously. We do not want to compromise vaccine confidence for other vaccines. Childhood vaccines are saving millions of lives every year. So we have to be sure, and that's why the regulators are taking this very seriously. The people that have been included in the trials are being followed up. And that's one of the things with when you provide regulatory approval or provisional regulatory approval for a vaccine in a pandemic or in an emergency, you want to follow up on those who first had it. And that's what's happening is tens of thousands of people that are involved in those initial trials are being followed up by the regulators to make sure that there are no long-term side effects that emerge.
And so I guess in relation to long-term side effects, some people have been concerned that some of these side effects and problems with vaccines or with drugs don't occur till several years later. We obviously haven't got the luxury to wait 2, 3, 5, 10 years, but you're confident to say to us, David, that these vaccines are safe.
Yes, look, and I think the key thing, Wayne, is that around the world, there's systems that are specifically honing in on vaccine safety and that take it very seriously, that any concerns that emerge, and we saw what happened in Scandinavia. There were a number of deaths that were actually occurred in people who received the Pfizer vaccine. These were elderly, frail folks in residential aged care who died in the weeks following the Pfizer vaccine. And that was jumped on by the regulators. They investigated every single one of those deaths to see if the vaccine was in any way responsible or contributed to the death. And that's what we want to see. They came out with a clean bill of health. These were people who would have died in that time. But we want to make sure that any safety signal is fully investigated, because we do not want to in any way compromise people's belief or trust and confidence in vaccines. So I'm confident that with the data we've got, there are no safety signals to date that anybody should be concerned about.
And you mentioned the Scandinavian example. There have been reports floating around social media that deaths are being hidden, and some of these side effects are being hidden from us, and that there are actually some terrible things happening overseas in regard to vaccination. But some of those reports are not quite true, from what I understand.
You're absolutely right. So there is an independent body of experts globally that goes fishing into every rumor that comes up. So they take the country-specific adverse events recording, and for example, in Australia, in New South Wales, every event that follows a vaccination is considered an adverse event following immunization that needs follow-up, needs investigation, and causality needs to be assessed. They take those, but they also follow up on rumors in media. And this group called GAFSC, the Global Advisory Committee on Vaccine Safety, basically trawls through good quality data and poor quality data, rumors and evidence, to make sure that no adverse events, important adverse events, are being missed. So I've got great confidence that there's a level of scrutiny, and an appropriate level of scrutiny globally, to make sure that there aren't any cover-ups and that any important signals are not being missed.
So another ethical question in relation to the development of vaccines. It's suggested that there's been a prevalent use of aborted fetuses in research. Can you speak to that in relation to the COVID vaccines?
Yeah, look, I can definitely confirm that neither of the vaccines that have regulatory approval in Australia, the Pfizer vaccine or the AstraZeneca Oxford vaccine, contain any tissue from aborted fetuses. Unfortunately, viruses, unlike bacteria can grow in a petri dish in a laboratory. Viruses aren't truly living organisms. They have to grow within cells. And so the viruses from which the gene for the spike protein that's included in the Oxford AstraZeneca vaccine was grown in a cell line, a human embryonic kidney cell line, from an abortion for another reason in 1973 in the Netherlands. Now, there's no aborted fetus tissue. This was simply to allow the virus to grow, and then the genetic code is harvested. And it's very interesting to know that this particular cell line has saved literally hundreds of thousands of deaths and disability, particularly in children, due to congenital rubella syndrome, because this is the same cell line that is used for actually providing viral growth for the rubella vaccine and for rabies vaccine, which is a terrible scourge, particularly in developing countries. So the Vatican itself has acknowledged that in relation to this particular cell line, that the double effect principle or double effect doctrine applies, which says that an outcome that is morally good from something that is morally bad is ethical as long as the morally good outcome was not the intention of the morally bad action. And so the Vatican has said, look, it's a great pity that this fetus was aborted, but that the use of the cell line has saved so many lives. The benefits have been so enormous that it's morally justifiable. And from a principle of sanctity of life, the Vatican themselves have actually supported it. So that probably, hopefully, addresses some of the concern that has been expressed.
The other one that's been floating around, David, you may have heard, is that these vaccines alter DNA. Are you able to speak to that?
Yeah, look, so the vaccine, the two that we're speaking about, don't go into the nucleus of our cells. They use the ribosome. So people can remember back to their biology lessons. Once the vaccine is in the cell, once that little spike protein genetic code is in the cell, it's read by our ribosome. So neither vaccine actually goes into the nucleus, will not change our genetic code.
Very good to hear. The anti-vax voices have obviously got louder as we've heard more about vaccines and getting the jab this year. You've had extensive frontline experience with disease eradication. What's your response to these voices getting louder, and even over these last few days, people demonstrating against being vaccinated?
The demonstrations have puzzled me somewhat, given that the Australian government is not mandating the vaccine, but we'll put that to one side. One of my favourite modern day authors is John Lennox, and John Lennox is the Emeritus Professor of Mathematics at the University of Oxford. He wrote a brilliant book, God's Undertaker Has Science Buried God? And in that book, there's a magnificent quote: faith is a response to evidence, not a rejoicing in the absence of evidence. And that's something which I strongly believe in. So my deep passion in public health has been to contribute to saving children's lives, mainly in low and middle income countries, from diseases that are prevented by vaccines. And Wayne, it's amazing. Since the year 2000, 37 million kids' lives have been saved in low and middle income countries due to vaccines just against 10 common childhood illnesses.
Wow.
Measles vaccine alone has averted 20 million deaths. 20 million children haven't died because we've managed to vaccinate them against measles. So as a scientist and as a believer, I would rather hold to the evidence than to misinformation or conspiracy theories.
I guess that probably answers my last question. And from your professional expertise, how would you articulate that we should be responding in the best interests of our nation, in the best interests of, as Christians, for loving and caring for other people in our community. What would your advice be for our response with these vaccines now available and in moving forward to see this pandemic eradicated?
Again, a great question, and probably after over 12 months of experience now with this virus and spending my evenings deeply entrenched in everything to do with the virus and its virology and public health measures and treatments and so on, it's quite clear that the only way out of this pandemic is through immunity. And there are two options: natural immunity, we expose everybody to the virus and we count the deaths because it does, and it kills particularly elderly people. But in recent months, the burden of long COVID has become quite shocking. And a recent study published showed that about 50% of people who survive 6 months later still have debilitating symptoms from their COVID infection. So it's not a laughing, it definitely isn't a trivial infection, not even in young people. So we either take the natural immunity route or we take vaccination. And honestly, with the rigor of the trials and the rigor of the regulators in terms of the safety and effectiveness of the vaccines, I know which camp I'm in. But as Christians, I think we also have an obligation, a moral obligation to people in our community who may not respond so well to vaccines. We know that elderly people's immune systems often don't generate as good a response. And we know that there are people who are immunosuppressed, who either have got cancer or cancer treatment and other conditions which make them more vulnerable. And so as a Christian, I think I have an obligation to them as well. As a scientist, I'm certainly willing to roll up my sleeve for a COVID vaccine. And as a Christian, I feel ethically obliged to receive a jab.
Thank you. So thank you very much, David, for joining us today and being a part of this interview. And again, we wish you the best. God bless you as you, I know you're working hard, and you've already told me you're in front of a camera doing Zoom meetings all over the world. And so again, we're praying for you, and we appreciate you. We appreciate the effort you're making, and all of our frontline workers, nurses, so many in our nation and around the world. So God bless you, and thank you.
Thank you so much, Wayne.